Good afternoon, and welcome to our series of web-based seminars on best practices in TB control. Today's seminar will focus on behavioral and social science implications for TB control. My name is Rajitha Bavaraju, and I'm a training and consultation specialist at the New Jersey Medical School Global Tuberculosis Institute. Our faculty today are myself and Dr. Wanda Walton, as well as Dr. Paul Coulson and Dr. Joan Mangan. Our first speaker is Dr. Wanda Walton. Dr. Walton is the Chief of the Communications, Education, and Behavioral Studies branch in the Division of Tuberculosis Elimination at the Centers for Disease Control and Prevention in Atlanta, Georgia. I'll now turn the program over to her. Wanda?
Thanks, Rajita. Today I'll be providing an overview of behavioral science and its role in TB control efforts. All of us who work in TB can agree with the statement from René and Jean Dubois in 1952. Tuberculosis is a social disease and presents problems that transcend the conventional medical approach. Behavioral science actually had its origin in TB. One of the earliest models developed to explain health behavior, the health belief model, was developed in the 1950s to examine motivators to participation in free TB screening programs as compared with the factors that lead others to not participate in these screening programs. Many factors influence individual behavior, including knowledge, attitudes, self-image, perceived risk, norms, self-efficacy, emotions, social influence, and personal advocacy. Some of these factors have more influence than others. Generally, why should we focus our efforts on behavioral science? We've recognized the limitations of medical technology in improving health and eliminating disease. For example, effective treatment for TB has been available for decades, but we have yet to eliminate this disease. We've also recognized the role of human behavior in health outcomes, with much of the current research focusing on influencers of behavior, such as social and cultural connections, as well as health systems and public policy. When trying to understand and create a positive influence on health behavior, behavioral science provides a way to place the interaction of health and behavior in a framework, better understand health behaviors, identify potential points for intervention, and influence behavior in a direction that promotes health. Interventions based on health behavior theories and models are not guaranteed to succeed, but they are more likely to produce desired outcomes. So why is behavioral science important to TB? Individual behavior, both patient and provider, is a key factor in preventing and treating TB. Adherence to the lengthy treatment regimens for latent TB infection and disease presents a major challenge for both patients and their healthcare providers. Especially acceptance and adherence to lengthy treatment for the asymptomatic condition of latent TB infection increases these challenges. On an individual basis, social and economic factors such as poverty, homelessness, substance abuse, availability of and accessibility to appropriate care and services, and TB knowledge, attitudes, and beliefs have a significant impact on the personal TB experience. In addition, TB control efforts are often challenged by the disparities in communities affected by TB. The 2000 Institute of Medicine report on the elimination of TB in the United States stated, "Studies are needed to determine how basic behavioral theories can enhance understanding for the creation of tailored interventions for high-risk populations." The report called for behavioral science research to explore the impact of behavior change models on health-seeking behavior and treatment adherence, identify cultural barriers to prevention, treatment, and control, as well as the role of incentives and enablers, tailor adherence interventions to patients' needs, lifestyles, and social support system and beliefs about health, and ensure translation of research into TB programs. In follow-up, CDC's Division of Tuberculosis Elimination convened the TB and Social Science Research Forum in December 2003 with over 60 partners and behavioral scientists to identify and prioritize TB behavioral and social science research gaps, guide TB behavioral and social science activities, build and establish partnerships among behavioral and social science researchers focusing on TB, and establish ongoing communication among researchers. So what's happened in the last 10 years? The Division of Tuberculosis Elimination's behavioral and social science research focuses largely on the major behavioral components influencing effective TB prevention and control. Issues including but not limited to treatment adherence, care-seeking behavior, patient-provider communication, perceptions of and ways to enhance the effectiveness of contact investigations, factors influencing acceptance of and adherence to latent TB infection treatment, and provider behaviors. Much of the research includes or targets pertinent high-risk populations such as minorities, foreign-born persons, and disenfranchised populations. Some specific behavioral and social science projects have included developing culturally and linguistically appropriate patient TB education materials, assessing the knowledge, attitudes, and culture-specific beliefs about latent TB infection among several high-risk groups, and identifying barriers to the acceptance, implementation, and adherence to the latent TB infection guidelines and development of strategies to overcome barriers. It's also included assessing TB knowledge, attitudes, beliefs, and practices among private providers serving foreign-born populations, addressing TB among African Americans in the Southeast to identify and overcome barriers to treatment adherence for latent TB infection and TB disease, and determining the acceptability and usability of interferon gamma release assays as compared with a tuberculin skin test among patients and providers. So I go back to my original question of why is behavioral science important to TB? Behavioral and social science research in TB has helped us better understand the behavior of TB patients and contacts as well as that of providers. Ongoing research is needed to understand the behaviors of both patients and providers and the impact of their actions on TB-related care-seeking, diagnosis, treatment success, and prevention. Today, you're going to hear from two researchers who've used behavioral science theories and models to structure and guide TB research. Dr. Paul Colson on using knowledge and attitude variables as predictors and outcomes, and Dr. Joan Mangan on identifying salient messages to address BCG vaccine misconceptions. And I'd like to point out both of them used the health belief model that had its origin in TB. So I thank you for your attendance today, and let's hear from our upcoming speakers.
Thank you so much, Wanda, for that very useful overview of behavioral and social sciences and some of the practical outcomes and projects that have been occurring recently, and as well as the origins of the social and behavioral sciences. I'd now like to turn the program over to Dr. Paul Colson. Dr. Colson is the program director at the Charles P. Felton National Tuberculosis Center, ICAP, at the Mailman School of Public Health at Columbia University. Paul, I'll turn the program over to you.
Thanks very much, Regina. I'd like to talk today about some investigations of TB knowledge and attitudes, or KNA, which we've undertaken. The purpose of this inquiry was to better understand what TB and LTBI patients were thinking about TB and its treatment, and what they knew, with the goal of improving treatment adherence and completion. This is a picture of a shelter I was working in the early 90s, the Fort Washington Men's Shelter in New York City. It's a little out of focus. This picture has gone through several generations, unfortunately. But you get an idea of what sort of environment this is. This shelter at that time held 1,200 men in a single large room. And it's probably pretty clear to this audience what the risks of TB transmission might be in such an environment. So I became involved while working in a psychiatry program in the shelter. And like many places in the U.S., New York City had seen a growing number of TB cases over the late 80s and early 90s. There was a large concern about TB, with the New York Post famously doing a cover story about catching TB while riding the subway. I was doing a postdoctoral fellowship, and I was reading a lot of KNA studies about HIV, but I couldn't find equivalent studies, or many equivalent studies, in tuberculosis. Most of the studies I was able to identify had been conducted in developing countries, often published in the International Journal of TB and Lung Disease. And these studies, while interesting, had limited applicability to the United States. They were largely descriptive studies. There were a few domestic KNA studies that were conducted in specific populations. You see on the slide here, drug users, immigrants, the homeless. Most of these studies assessed TB knowledge, but did not give attention to attitudes. And probably more importantly, they tended not to be guided by any sort of theoretical model. This left me with the situation of having to develop a questionnaire And the way I did that was through several steps. I initially conducted focus groups with homeless men in that shelter that you saw the picture of, and also TB and LTBI patients at Harlem Hospital. I developed the first draft of questionnaire, which I tested for face validity with physicians, other researchers, and service providers. And then I piloted the questionnaire with target respondents regarding their comprehension of the items, their understanding, looking at specific language choices. So I developed a number of knowledge items, and this is one area actually where I could draw on somewhat from some previous studies, particularly a study of the homeless by Jacqueline Tulski in San Francisco, and a study of injecting drug users by Hannah Wolf here in New York. Basically, I developed true-false items that tested their knowledge of three topics: transmission of TB, how we test and what the testing means for TB, and how it's treated. And you could take each of these items individually to examine it, or you could also total up the correct responses to make an overall knowledge score. Wanda had referred to the health belief model, and I just want to briefly talk about a couple of these theoretical models because, as I said, I think it's important to consider attitudes and not just knowledge. Knowledge is something that obviously we can try to improve through health education. What's known about attitudes is a little more murky, and what the role of specific attitudes are is still something we need to explore more. But looking at the health belief model, obviously here's knowledge under a modifying factor. And the health belief model suggests there's something called perceived threat, or sometimes also called perceived risk, which is made up of a person's beliefs about their susceptibility to a disease and how severe the disease is. So obviously, one might say, well, I could get a cold at any time, but, colds are a pain, but they're not so serious. And so you might feel sort of relatively low perceived risk about colds. Tuberculosis, HIV, obviously, will be a different constellation of the severity of the disease. Certainly is a more serious disease than a cold. Susceptibility, you may feel as an individual that you're not very susceptible, you're not likely to get TB. So these all go into a person's perceived risk. And also what people weigh in considering health actions is their perceived benefits and what they perceive as barriers too. So these are sort of the intrapsychic factors we're looking at. The health belief model also talks about cues to action. You see at the bottom box here, which are external factors that induce people to act on their health beliefs. It might be a physician reminding the patient to consistently take their medication. It could be a patient themselves figuring out a strategy, say having their medicines next to the toothbrush so they remember to take their medicine at night before going to bed. Another theory that I tried to use in developing items was a theory of reasoned action. And this looks a bit more at intrapsychic factors compared to the health belief model. And generally it suggests that one not only acknowledges how other people view a certain issue, but whether you're motivated to follow that norm or to act differently. So to give a non-TB example, your teenager may realize that you and your immediate family frowns upon premarital sex, but he or she goes ahead and does it anyway, right? They know what the norm is. Premarital sex is not good, but for a variety of reasons, they go ahead and do it. All right, think about LTBI for a minute. Your family's belief system may be that when a doctor prescribes something, you take that medicine. But it might be that you don't see the point. You think it's a hassle taking a pill every day, and you don't feel sick, so you don't take it. So that's somewhat here in the chart, recognizing what the normative beliefs are, and then what is your motivation to comply, and that leads to a subjective norm. In a similar way, you might be a homeless person living in a shelter, and your belief is if you take care of yourself, eat right, get enough sleep, you'll be healthy. But as you look around you, there's other guys in the shelter who are doing the same thing, but they're getting sick with TB. So that would have an impact on your behavior, your attitude toward that behavior. I also looked at a number of other theoretical models. I don't want to suggest that my research has been guided by a single theoretical model. I don't think in TB knowledge and attitudes we're at that level of understanding about these issues yet. So what I was doing was looking at a variety of theoretical models that might be useful, including the idea of self-efficacy that Albert Bandura put forward. Self-efficacy is essentially one's belief that you can accomplish a certain thing. And it's viewed as being important in HIV, but also in tuberculosis. In HIV, the way it's often expressed is that you believe you can consistently use condoms despite having different types of partners, having different kinds of social pressure, perhaps being intoxicated. So, or even facing a resistant partner. Do you believe you can go ahead and do what you believe is the right thing? So that's self-efficacy. Health locus of control is an interesting concept that hasn't often played out very well in research studies. That relates to the idea that whether you believe health outcomes are due to your own behavior, your own efforts, in which case you have the internal locus of control, or whether your health outcomes are due to external factors, such as your physician, or God, or fate. That would be a person who has a strong belief with external locus of control belief. Stigma certainly is a factor that needs to be explored in a infectious disease like tuberculosis. Probably all aware that tuberculosis is very stigmatized around the world. Acknowledging status, it's not a very fancy term, but I have found that in my research that people who simply don't believe that they're infected with TB, that winds up being a major factor, whether they're adherent or whether they can start treatment. And finally, intentions. People have intentions of varying strength. Some people say, well, yeah, I'll go ahead and take the medicine as long as, it's easy, but then when they run into barriers, it goes out the window. This is a number of studies that my colleagues and I have conducted around tuberculosis knowledge and attitudes. The ones in red are the ones I'll be discussing today. The first study I'd like to talk about is the initial one I did, where I told you about the formative work in terms of interviewing homeless men. At the HIV Center of Clinical and Behavioral Studies in New York, where I was doing my postdoc, there were 6 HIV studies being conducted, and I was able to implement a common questionnaire about tuberculosis knowledge and attitudes across these 848 participants. And in all these cases, data was collected in the same manner through face-to-face interviews. People in these studies were all at varying levels of risk of tuberculosis. Nobody in this study was being treated for TB or LTBI. Certainly a number of people in these different samples came from poor neighborhoods, came from other countries, lived in crowded conditions, particularly shelter. So as I say, they had varying levels of risk for TB and varying levels of knowledge. So I just wanted to point out some of the major findings. I found significant misconceptions about the casual transmission of TB. People thinking that they could get it on the subway, they could get it from passing a stranger who was coughing. There was a fair amount of confusion with HIV. Many people thought that TB was not curable, as HIV is not curable. Many people thought it could be transmitted through sexual activity, which tuberculosis is not. And there's generally confusion about infection versus disease. Now, I know from a variety of other studies that's very common, and even among healthcare professionals, there's often not clarity about the distinction between infection and disease. I did see an association between age and knowledge, that the older people had more accurate knowledge about TB, perhaps from being alive longer, perhaps from having known relatives or distant family members who had been treated for TB in the 40s or 50s. Homeless people had more accurate information about testing and treatment, something I attribute to the fact that living in congregate settings like shelters and jails, they were probably encouraged to undergo LTBI treatment. So now I'd like to talk about another study, and The study I just talked about, the HIV Center study, offered only descriptive findings about the participants' knowledge and attitudes. In this study, I was able to take those descriptive findings from another sample and compare two groups. And this was a randomized clinical trial that was funded by the National Heart, Lung, and Blood Institute. And what you see here is the title and the site, etc., for where you could find that article if you're interested in reading it. The larger study was called the Tuberculosis Adherence Partnership Alliance Study, briefly said TAPAS. 251 patients who were receiving treatment for LTBI, two-thirds of which were foreign-born. And all the people who were foreign-born were from TB endemic countries, generally Central and South America, and a number of people also from Africa. And the reason this is important to look at the foreign-born is because the foreign-born represents 62% of the TB cases in the United States and 73% of the people under LTBI treatment in the United States. So the design of TAPAS was a randomized clinical trial that was testing a peer-based intervention to enhance adherence to LTBI treatment. We looked at knowledge and attitudes at baseline, and the main effect of this study is reported in a separate paper that's under review right now. But what I did was just took the knowledge and attitudes data and compared the U.S. and foreign-born participants. Briefly, the findings were that, like the previous study, there were misconceptions, particularly around transmitting TB through kissing, and that strangers would be more likely to give TB to you than a family member, which we all know is not true, and that there were not overall differences between the foreign-born and the U.S.-born in terms of the levels of knowledge. In terms of attitudes, there were no differences on 10 out of 17 items. The U.S.-born participants more likely to acknowledge LTBI, to be concerned about the reaction of family and friends, to worry about passing TB germs. Foreign-born more likely to feel protected, most likely because many of them had received BCG vaccination. In terms of their assessment of benefits and barriers, there were not, again, large overall differences. The foreign-born were more likely to be concerned for their family, worried about stigma, and to find pill-taking difficult. I'd like to move to another study. In 2001, the CDC formed the Tuberculosis Epidemiologic Studies Consortium. The consortium had the express purpose of conducting epidemiologic, behavioral, economic, and programmatic research in TB and LTBI in the U.S. and Canada. In the consortium's first 10-year cycle, a number of studies with a behavioral focus were conducted, and Wanda mentioned several of them in one of her final slides. I'd like to focus on two TBSC studies in which I was involved, task orders 13 and 9. As with the other studies, we had examined individual knowledge and attitudes items and ran cross-tabulations to explore differences across groups. First, to talk about task order 13. This included 1,692 people who were offered LTBI treatment in 30 clinics in the U.S. and Canada. When I said offered LTBI treatment, that's important because most LTBI studies simply take a group of patients who have been prescribed, who started LTBI treatment, and then follow them. This study started at the point where people were offered treatment, and many people refused treatment. And that allowed us to examine that because the people who refused treatment were also interviewed at baseline. So we conducted this study, which, as the slide shows you, examined demographics, life circumstances, knowledge and attitudes, experiences with health care, and clinical characteristics. What this study allowed us to do, unlike the previous studies, is to use multivariable techniques to look at knowledge and attitudes and other factors against an overall outcome, which in this case is treatment acceptance. And I know this table is maybe a little difficult to read, but let me point out some of the main things. Again, I'm sure that many people understand the distinction here of being able to run a multivariable equation, because that tells you it takes a number of factors which may be all related to each other in various ways and identifies the independent contribution of each of the factors to the outcome. So some of these items here are knowledge and attitudes, and some of them are more circumstantial things. I mean, healthcare workers, well, essentially the factors listed up at the top were factors, if you look at the adjusted odds ratio column, when it's above 1, these are factors that encourage treatment acceptance or were associated with treatment acceptance. Odds ratios below 1 generally suggest that these are factors that discouraged treatment acceptance or led to declining treatment. So people who are healthcare workers were more likely to decline LTBI treatment than non-healthcare workers. If you had been recommended for treatment in the past, you are more likely to decline again. If you thought that taking medicines would be a problem, you are likely to decline. Speaking of other attitudes, a person who believes they can personally spread TB germs was more likely to accept treatment. That's sort of interesting because we all know that a person with LTBI cannot spread germs. But if you have that false belief, you're more likely to accept treatment. People with better knowledge, for the most part, were more likely to accept treatment. People who thought that the clinic schedule would not be inconvenient were more likely to accept treatment. And finally, in terms of acculturation, people with low acculturation, that's people who are more recently arrived in the U.S., who don't speak English as well, were more likely to accept. And people who had high acculturation were more likely to decline treatment. I should just say, too, this sort of analysis about what's predicting treatment acceptance has been paired also. We have a separate paper using the same techniques to look at treatment completion that also uses both circumstantial factors and knowledge and attitudes variables. Finally, I'd like to talk about the paper that we've published from Task Order 9, which was a study of foreign-born TB cases, 1,475 foreign-born persons diagnosed with TB in 22 sites. Again, it examines similar factors as you saw in the slide about Task Order 13, with a bit more attention on how people came into care, which is a very important issue for foreign-born, both because of the whole immigration process and then also what sort of efforts and messages they're given once they're in the United States. Again, there's a particular interest in missed opportunities in that process of considering coming to the United States and actually coming. What's a little different about this, I started out with talking about a descriptive study, the HIV Center study, and then the TAPA study, which compared U.S. and foreign-born, and then Task Order 13, where we predicted treatment outcomes using knowledge, attitudes, and other variables. Task Order 9 is different in that it sort of turns on its head. Instead of trying to use knowledge and attitudes to look at an outcome, we tried to figure out what is predicting knowledge and attitudes. We did factor analysis of people's responses to the knowledge and attitudes items, some 30 or so items, and came up with two factors. One was a knowledge factor, and one was a perceived risk or stigma factor. So then we used multivariable techniques to examine what was predicting separately, knowledge and perceived risk or stigma. Again, one can look at the article to see the elaborate tables, and this is sort of a brief summary of what those tables would tell you. The higher levels of knowledge came from, was greatly dependent on what region of the world one came from, but Mexicans and Latin Americans seemed to score higher. People with higher education and higher income also scored higher on TB knowledge. Again, these are multivariable techniques, so these are independent contributions. You might say, well, people with higher education probably have higher income also. Okay, but in this case, using multivariable techniques, it shows that despite what your income is, if you have higher education, you're more likely to have higher knowledge. Or despite what your education was, if you had higher income, you had higher knowledge. Older people had better knowledge. People who are undocumented, interestingly enough, had better knowledge about TB. People who were BCG vaccinated, and people who had more symptoms of TB tended to have better knowledge. Then the other factor that came out in the factor analysis was feelings of perceived risk and stigma. Again, region of the world was important, and Mexicans seemed to score the highest on these feelings of perceived risk or stigma. People who are middle-aged felt more perceived risk, stigma. people who are more fluent in English, people who had been in the U.S. or Canada for 2 to 3 years, which is kind of interesting. It wasn't the new arrivals who felt more perceived risk or stigma or the people who had been here for a long time. It was the people who had been here a couple of years. It's kind of hard to understand what that means. Again, people with greater numbers of symptoms might feel more risk. It's understandable. People living in crowded conditions. I just want to say where we're going with this analysis. There's one more task order, 23, from the original 10-year cycle that we have data, and that study looked at U.S.-born African Americans compared to U.S.-born whites with TB. So we're just analyzing that data now. Having used sort of a common pool of questionnaire items across these studies would allow me to try to do a comparison across populations by seeing how people responded to the same item. And a final thing I plan to do is, for some of these studies, we measured knowledge and attitudes both at baseline and at the ending of treatment, and that would also be another analysis I'd like to undertake, is to examine changes in knowledge and attitudes over time. Thank you very much for your attention. I'll turn it over now to Dr. Mangan.
Thank you so much, Paul, for your wonderful overview of some of the behavioral science theories that you used, as well as your findings on your different studies looking at the knowledges and attitudes about tuberculosis. I'd like to now turn the program over to our last speaker, Dr. Joan Mangan. Dr. Mangan is a behavioral scientist at the Centers for Disease Control and Prevention in the Division of Tuberculosis Elimination. Joan, I'll turn it over to you.
I'll echo the other speakers and just say thank you so much for joining us today. There have been a number of excellent studies that have explored people's knowledge, attitudes, and beliefs about tuberculosis, and this has been quite informative for tuberculosis control, and I think Dr. Colson's talk really illustrates this for us. Today, I'm going to be sharing the results of a project where my colleagues and I took some findings from other researchers who had looked at KAP, and we tried to take it a step further, very much focusing on misperceptions surrounding the BCG vaccine. So for the next 20 minutes, I'm going to outline the impact myths and misconceptions have on TB control, review some of the misconceptions TB suspects and contacts commonly report related to the vaccine, and then TB treatment. I'd also like to, as I said, discuss results from some of these from the project where we sought to identify effective messages. The myths and misconceptions surrounding TB are amongst the most effective means for stigmatizing patients, engendering secrecy, eroding self-esteem, altering people's behavior, generating mistrust, and creating social outcasts and impoverishment. If the elimination of tuberculosis is going to be a reality, we must address the myths and misconceptions surrounding the disease. A lot of people will talk about, providing the factual information to patients, but why do we care about these myths and misconceptions? Research has demonstrated when individuals are provided information that appears inconsistent with existing beliefs or behaviors, there's a dissonance or a conflict that may lead some individuals to either purposefully avoid or ignore new information. Some people might downplay the importance of the information, and others might add interpretations that are consistent with existing beliefs, behaviors, or personal characteristics. So in essence, they're trying to reconcile some of the old information with the new information they're being provided. All of these types of responses can enable a biased optimism or the belief that the person is going to stay well despite their risk. So let's talk about the misconceptions specifically surrounding the BCG vaccine. Currently, it is the only medically available TB vaccine. It's been distributed since the 1920s, and more than 3 billion individuals have been vaccinated worldwide. A number of countries employ large-scale vaccination campaigns that include the BCG to control infectious diseases. And these campaigns are often supported by mass media promotions that extol the benefits of vaccination and include appeals to parents to ensure their children's health. Whereas these campaigns ensure high vaccination rates, it can also contribute to 3 common misconceptions. The BCG vaccine protects a person from becoming sick with TB throughout their entire life, that a positive TB screening test is caused by having been vaccinated with BCG and not from infection, and if BCG vaccinated, treatment for TB infection is not necessary. Prior to coming to CDC, colleagues and I wrote a grant and we submitted it. It was funded by the American Lung Association. This grant that my colleagues and I wrote while I was before I came to CDC, really the aim of it was to identify the salient messages that were going to help to mitigate some of that dissonance or some of the conflict Hispanic persons may experience relative to having been vaccinated with BCG and subsequently being informed that they should be tested and or treated for TB infection. And we really thought to do this in a very systematic way, and this slide just kind of provides the project to you in a bit of a nutshell. But we did do it in 4 phases, and I'm going to go into these in a little bit more detail. But first, we started off by approaching providers and asking them to provide messages to us. My colleagues and I organized these message statements into thematic groups. Then we sought to validate the statements that we had collected, select those that we were going to take forward and test with members of the target audience, and then we did 2 phases of testing. In the first, we went out and we started off with individuals who had a previous diagnosis of either TB or LTBI, and then we went out with a larger group of Hispanic individuals who had never been diagnosed with TB or LTBI. And then finally, we took our statements and we brought them back together to combine more comprehensive or robust messages, and we took these out as well to members of the target audience to solicit their input on these messages. So let me go into a little bit more detail and show you some of the results. So in that phase 1, the staff members that we went out and collected messages from, there were a total of 60 staff members. They came from 5 TB programs, including Virginia, Florida, Alabama, South Carolina, and Illinois. And we provided them the 3 common BCG misperceptions that I had provided earlier. And we asked them to go ahead and write out the messages that they had used to persuade BCG-vaccinated TB suspects and contacts to undergo TB testing and treatment. Then my colleagues and I sat down and we did a very systematic analysis of the messages that everyone had provided. And we saw that even though there were 3 misperceptions, there were a lot of common messages and themes repeated across that the staff had provided to us. So we turned around and we organized these statements into what we were calling 7 thematic groups. And here they are. The first group we kind of titled, in general, why is BCG given? And we saw that some of the messages focused on where the vaccine was used, who is given the vaccine, and why children are given the vaccine. The second set of messages really focused on why BCG helps to decrease the risk of developing severe forms of TB. The third group of messages was why the vaccine is not completely effective and that the protection wanes. The fourth group were message statements that tried to provide evidence of the vaccine's protection waning, and this included discussing things like incidence of TB around the world, testing outcomes, and the clinical picture, or the signs and symptoms of illness of people who had been vaccinated. The fifth group focused in on reasons for getting tested for TB, and these message statements talked about the vaccine's limitations, why it was important to know your test results, what a person would gain from being tested, and what a person would lose from not being tested. And then finally, the last 2 groups included the testing process itself and test results and treatment. So my colleagues and I, when we were going to go forward and start testing the messages, we opted to focus on the first 5 groups. We did not include the message statements from groups 6 and 7, and this reason was twofold. First, when we looked at all the message statements we had in the first 5 groups, there was quite a few of them. And we realized if we were going to go out and do focus groups, it would be a lot of asking people, what do you think? Why do you like this? Why don't you like this? And if you keep doing that over a period of time, people get a little fatigued, and we didn't want to get perfunctory responses. Secondly, when we're talking about the testing process, test results, and the treatment, that tends to be a little bit more factual. So we opted to focus instead on the first 5 groups. In phase 2, we took these message statements in the first 5 groups, and then we had them reviewed by TB experts. And we went through and we were deleting some messages that could be inaccurate in different contexts. We tried to edit some of the statements to improve their reading ease or their comprehensibility, and a lot of this was taking out some of the very scientific terms and trying to bring in more lay language. And then, of course, establishing the validity of the content of the messages. At that point, then we sat there and we said, okay, we've got these messages. Now we need to select which ones are going to go into the testing phase. And again, we were focusing on the very accurate statements. We wanted statements that would be representative of other messages in the group. And we were using health theories and models to try and help us discern which messages we were going to use. And we focused on 3. The health belief model, which Dr. Walton and Dr. Colson have already discussed, so I won't go into detail. The elaboration likelihood method, And in this method, there's two routes by which you would persuade somebody to take action. The first is the central route, and this is where you're providing information that would kind of cue an individual to use some of their existing knowledge or their existing experiences to evaluate what it is that you're suggesting to them, and then also evaluate the feasibility and the desirability of what you're suggesting. The other is the peripheral route, and this is where you really try and cue a person to kind of have a bit of an attitudinal or an emotional response to what is being said. So you might look to cue them to be very excited about something or very nervous or anxious in order to get them to take action. But the impact of this type of messaging, you typically see it to be very short-term. It won't take you through a longer period of time. And then finally, we were looking at framing of actions. And I'm going to go into a little bit more detail on framing of actions because we spent a lot of time really looking at this piece of the messaging. But you can frame things in a very positive way or a very negative way. You could frame things in a way so that you show people what they're going to gain or what they're going to lose. And I'll go into more detail. Once we had these messages and we did make our selections, then we wanted to identify which ones were the most persuasive. So as I stated before, we did do semi-structured interviews. We brought together 10 foreign-born Hispanic persons who had been diagnosed with either TB disease or latent TB infection. These individuals, most of them, when we did interview them, were undergoing therapy at the time. Out of the 10, 70% were male. They ranged in age from 19 to 71 years, and their average age was about 40. Their countries of birth included Cuba, Mexico, Guatemala, Peru, and Uruguay. About 30% had resided in the U.S. for more than 5 years. We got their feedback. We made a few little tweaks. And then we turned around and we conducted 4 semi-structured focus group interviews with 43 Hispanic persons who worked with or sought services from a community organization that aimed to assist migrant workers. None of the individuals that we interviewed had a prior diagnosis of TB disease or LTBI from a physician. And out of these 43 individuals, 75% were female. They ranged in age between 18 and 67 years. Again, the average age was 37.9 years. 60.5% of them had a 6th grade education or less, and their countries of birth included Mexico, Argentina, Honduras, Puerto Rico, and we did have 5 individuals who were actually U.S. born, but they had lived and worked in the migrant community their entire lives. When we got their feedback on which message statements they liked the most, it was very interesting because we were seeing that there was a bit of a pattern. They did prefer messages that were focusing their attention on obtaining a positive result, which is coming from the positive action framing. They preferred messages that addressed perceived susceptibility from the health belief model. And they were also preferring messages that were encouraging them to evaluate the issues by drawing upon their prior experiences and knowledge, which again is that central route from the elaboration likelihood model. So once we had their feedback on all of these statements, then we were aiming to turn around and build more comprehensive messages from all the statements together. And there were a number of considerations that went into this. First off, we were looking at the readability. We were really aiming to have message statements that were going to require a grade level between 6 and 7, and we wanted a flesh reading E-score of 70% or higher, meaning approximately 70% of the population would be able to read it pretty easily. We had a lot of debate on using either a long message or short messages. And part of this was based on our experiences going into these focus groups. A lot of the participants really liked seeing all the message statements. They liked that it was very descriptive. They felt it was very informative. And they appreciated seeing all the information in context. But we also appreciate that if we went out with very long messages, this could get a little overwhelming and some people might find them too complex. Less is more. Going with the shorter message could be very helpful. But you'll recall at the very beginning I talked about that biased optimism, where people will sometimes try and reconcile old information with new. So if we had too short of a message, would people remain unconvinced and still think that they were protected? We did spend a lot of time, again, looking at positive and negative framed, gain framed, and loss framed. And again, positive frame, negative frame is using either positive words, terms, or phrases versus negative words, terms, or phrases. And the gain frame versus loss frame, this is where you talk really about the advantages of adhering with whatever the recommendation is versus the disadvantages or the consequences of not following what was being recommended. And this caused us a lot of back and forth conversation amongst the investigators. Because why really look at this message framing? It's been long held that framing can lead to different decisions and different behaviors. And here's an example of statements for just taking the LTBI treatment. You know, to sit there and say this is positively framed or game framed, you say, get the best care available and stay healthy. Take the LTBI treatment. Versus a more negatively framed statement, which would be something along the lines of, don't get sick with a disease that can kill you. Take the LTBI treatment. And the other reason that we were really going back and forth on this positive versus negative framing was there's been a number of papers looking at this issue, and Rossman and Solovey in 1997 did a review of a number of studies, and they came forward with some recommendations after reviewing other people's work that said, if whatever you're advocating is prevention-oriented, such as LTBI treatment, you're better served by a positively framed message. Whereas if you are doing something that's detection-oriented, such as testing for TB infection, again, this is better promoted by a negatively framed message. So we're trying to convince people to do both when you're going out and doing those contact investigations. After much deliberation, my colleagues and I decided that we were going to go forward and we were going to test 4 messages total. We were going to use a long, comprehensive message to appeal to the people who like the information and context. And to create this message, we were using those statements that earned the most votes in each of the 5 thematic groups, and that we were really aiming to get both positive and negatively framed statements represented. And then of the short messages, and we titled these B, C, and D, message B was primarily negatively framed, message C was primarily positively framed, and message D was a combination of both positive and negatively framed statements. I'd like to share a little of the feedback that when we went back out and we tested these messages with you. We had a total of 8 individuals where we sat down and we did one-on-one in-depth interviews. These individuals were recruited through a community-based organization, again, that served migrant workers. None of them have been diagnosed with TB or LTBI prior to the interviews. Most have been vaccinated with BCG as a child. 75% were able to say yes, they were. 1 person was unsure, and 1 person reported that they had not been vaccinated, and actually they had been born in the United States. The gender of the group, it was 25% male versus 75% female. Age range, again, was 27 to 56 years with an average of 35.9. 38% of the group had a 6th grade education or less. The majority had resided in the U.S. for more than 5 years. And again, the countries of birth represented were Mexico, Honduras, and the 1 individual who had been born in the U.S. and had been back and forth. So let's talk a little bit about that long message. This was composed of 13 sentences, which could be a very, very long message, but we envisioned, perhaps this could be something that would be put into a brochure. It could form some script for some video or for some public service announcements, or it could kind of provide a script for somebody who's going to go in and have a conversation with the patient. When we did the readability calculations, the English version of it was coming in with a grade level between 6 and 7, and the English version, again, if we did the Flesch-Kincaid reading score, came in as fairly easy. It scored a 74.9. So again, approximately 75% of the population should be able to read this. When we took the Spanish version of the message in through the readability calculations, the Fernandez-Huerta score is very similar to the Flesch-Kincaid, and it scored a 93, so it was considered very easy. These 13 sentences that made up the long message, we sat down with the interviewees, presented them as 6 message statements, and had a lot of discussion on what do you like about it, what don't you like about it, and asked them to sit there after going through each of the statements and discussing them, going through the entire message and asking people, go ahead and tell me the message back in your own terms. So this is long message A, and again, like I said, this would serve more as a script. BCG is used in countries where many people are sick with tuberculosis. Small children have an immature immune system. Because they may be exposed to persons with TB, the vaccine is given to babies and small children. Many people think the BCG vaccine will protect them from TB for their entire life. However, the vaccine does not always prevent tuberculosis. If a person breathes in TB germs, the vaccine helps to lower the chance a person will develop severe forms of TB or die from TB. But people who have had the BCG vaccine can still get sick from tuberculosis. We have tested other people in your country who were given the vaccine, and their tests were negative. This shows that your positive test is probably the result of contact with a person who is sick with TB disease and not from the vaccine. Do not take a chance with your health. If the tests show the TB germs are in your body, take the treatment because TB can kill you. With no treatment, you can get sick and spread TB germs to your family and friends. Get treated, stay healthy, and keep those you love safe from TB. Now you see in this slide that some of the text is in blue and some of it is in bolded black font. The text that's in bolded black font, when we read the entire message to the participants and we said, tell us in your own words this statement, what you're getting from this, 50% or more of the participants reiterated the concepts in these statements back to us. So again, these are probably the most salient pieces of this message that immediately people were able to reiterate for us. When we asked the participants to report their thoughts as they listened to message A, half of the participants indicated that they had contemplated their own or family members' susceptibility to TB, again, going back to that health belief model. Others discussed an increase in perceptions of the disease's severity. Again, this is health belief model. Some had expressed the belief that when they immigrated to the U.S., they had left the problem of TB behind in their country of birth. And this is going to the elaboration likelihood model where you use that central root, where you get people to kind of reflect back on their own knowledge and experiences. When we asked the participants what information needed to be clarified in this message or what information should be added, it was interesting. One of the individuals came back and asked us if we could define an immature immune system. And my colleagues and I, we really had a lot of debate whether we should even keep that sentence in the long message. But when we had gone through the focus groups with 53 individuals, this was a message that had risen to the top and had elicited a lot of votes. So we did. And out of this group, we did have somebody who asked us to define that. One participant asked us to explain whether a person with LTBI could infect others. Two of the participants wanted there to be an explanation of how TB germs get into the air. One participant asked us to explain who is at greater risk for becoming sick with TB disease. And then we also had a participant who asked us to explain the difference between the vaccine and the test. And it was interesting to see this come back out to us in this round of focus groups because we had heard this before when we were initially testing the initial message statements. Because it was repeated to us on a number of occasions, people perceive the TST test to either be a treatment in of itself or to be a booster vaccination. When we asked participants to state what they liked best about the messages, there were three things that came out of this conversation. First, the participants liked the explanation that the vaccine lowers a person's chance of developing severe forms of TB if the germs are inhaled. They appreciated the advice that a person not take a chance with their health, and they also appreciated the encouragement to take treatment to protect a loved one. After having these conversations regarding the long message, then we sat there and we started to review the short messages with the participants. And again, you see the types of messaging that we used. Each of the short statements was read and discussed, and then the participants were asked to select the messages they liked best. And out of the group, one participant liked B the best, the negatively framed. 3 liked C, which was the positively framed. 3 liked D, which included both positive and negative frames. And one person reported that they liked D, but that they better understood C. Then, after they told us which one they liked, we took that selected message and we discussed it further. And because of time constraints, I'm not going to go into a lot of information here, but I am going to share at least message C with you. And you can see the readability scores on this again. And this message was, we still have a lot of TB disease in the world. Most of the TB is found in countries that use the BCG vaccine. If the vaccine protected a person for life, tuberculosis would not be a problem in the world. Knowledge is power, and we can protect ourselves from disease. Knowing the protection from the vaccine wears off, it is important to be tested for TB. Find out if the TB germs are in your body and if you need medicine. If your tests show germs are in your body, you need to be treated. Treatment will help you stay healthy and keep those you love safe from tuberculosis. You can see the first two statements there. Again, looking at that elaboration likelihood model where it's the central root, where you ask people, think about, you already have knowledge, you already have experience, and those first two statements are tapping into that to get the person to really evaluate the situation. I am going to share with you some of the take-home lessons that we took out of this project. The positive and gain frame messages certainly worked a little bit better. And this is consistent with some of the other literature that's out there that says if you use the negative, again, you get a short-term effect. You might get people to do something immediately, but it doesn't always carry through. You know, that fear, that anxiety doesn't carry through something like 9 months of INH treatment. People appreciated statements that were illustrating their personal susceptibility, such as how people are infected and who is at higher risk for infection and disease. People appreciated statements that were going to encourage them, again, to evaluate based on their prior knowledge. Also, it was important to check for some cognitive dissonance. This is where you would, as a provider in a clinic, ask patients to repeat information back in their own words or invite them to talk about what the provided information means to them. We saw this come out quite frequently as we were doing our interviews, where people still, even after they had been exposed to all of these message statements, we still had a couple in the crowd that would go back and try and reconcile some of the old information in with the new. Would strongly encourage you to always check for that cognitive dissonance. Finally, explain the difference between the BCG vaccine and the PSC test. As I said before, we were hearing quite frequently that people thought that this was a treatment or a revaccination. Always be mindful of the literacy demand, and then that systematic process for health education, whatever you're going to do, is so important. It helped us, and we recognize even with these messages, we were so systematic, but they could probably do with a little bit more refinement. This project was quite labor-intensive, and there are so many people to thank. And I've got them listed here, but I just want to acknowledge my co-investigators, Dr. Galindo and Dr. Irani at the University of Florida, and certainly Dr. Wanda Walton and Amr Khan, because once I came here to CDC, they were very supportive of this work. Thank you very much.
Thank you so much, Joan, for that great overview of how you use the behavioral sciences as well as the theories that we've already discussed to develop your message points and sort of retest them. We now have some time for discussion with all the presenters. I'm going to start with the first question, and the question actually can go out to all three of you. And it was a good question about whether you know of studies or is there work being done on looking at the differences in gender and attitudes related to women and men getting TB, and any studies that have been done or any work that's been called out to do that. And I'll send that out to any of the presenters.
Regina, this is Wanda. I know we haven't had so much in the United States of this, but I know there are a number of other countries that have done this, and that's a lot of it is based on the fact that in other countries, it's based on the country is who is getting the disease. I was a reviewer on a paper regarding a study that was done in Pakistan, and I believe in that country the majority of people with TB were women. And so they were looking at those aspects and focusing on that population. But not some, I don't know of any really in the United States. Paul, do you know of any?
I'm not sure of anybody looking at differences in knowledge and attitudes across gender. Certainly the epidemiology, you're right, Wanda, in different countries, like in South Africa, TB is mostly in men and often in minors and people working in sort of congregate settings like mine. But I'm not aware of studies that have looked at differences in gender.
Thank you. I know that there have been some calls, as Wanda mentioned, internationally, Paul, as well, you've mentioned that, to actually disaggregate some of the data and actually look at those gender differences with data that already exists. So I think there's been a lot of work done in calling to actually look at some of those differences. And so you're right, I think research has been done in that area. Joan, a question came through about the use of interpreters for your focus groups and your interviews, and perhaps how that might have affected responses that came through in terms of your discussion with them.
There was no interpreters used because the investigators were actually bilingual. We recorded all of the interviews, and we did have an individual who was a native Spanish speaker who transcribed all of the interviews, and then they were translated into English. The translation was checked by one of the other investigators so that Tracy Irani and I, who are not as fluent in Spanish, were able to sit there and look at the data. So no, we did not require interpreters. All interviews were conducted in Spanish.
Thank you for that clarification. I'm wondering from a practical standpoint, looking at the National TB Indicators Project, there's a number of variables and benchmarks which are being used to evaluate programs. And I'm wondering how some of the work you've talked about in the behavioral health sciences can be used, how programs could use them to to evaluate some of the outcomes and things that they're trying to increase their quality in. So, for example, things like completion of therapy or getting contacts examined. What are some things that perhaps can be done or have been done? And I know, Wanda, you did mention some examples of some studies that are being already done.
The main focus of any of this research is to inform interventions. And those interventions could be change in practice, it could be change in guidelines, it could be change or development of educational materials or training courses. So we, behavioral science, we have people who their primary focus is behavioral science, but we also have many health educators who are working in TB who utilize both behavioral science in their research following the systematic process, as well as the development of those interventions or education materials. Materials that are coming out of CDC, Division of Tuberculosis Elimination, all of our materials that we have, educational materials, have utilized the behavioral research that has been going on. And I know the regional training and medical consultation centers are doing the same thing. Whenever they do the systematic process, they're actually looking at the needs for the target audience and then testing the materials and interventions with patients and provider groups. All of these things work together, and many of us often set the groups that work to develop new guidelines and new interventions. All of us have well integrated ourselves into how we can influence the practice and help people in their day-to-day activities in TB control programs.
Thank you, Wanda, for that explanation in terms of how the research is being used on a more practical level.
Can I just add one thing? And this is it's not directly responsive to what Wanda's saying. I think her branch is doing some great stuff. I guess one thing, as a take-home message I'd like to say to people is think of health education as a conversation, not a lecture. I mean, too often I see health educators who just talk at patients, and there's a lot of important information to share, certainly. But, given some of the factors we've talked about, the feelings of perceived susceptibility and what people know from their home countries, there really has to be a give and take back and forth. And you have to explore with people what is hard about this or what don't you understand or what do you think will be difficult about doing this treatment. It's more sort of moving to counseling than lecturing.
That's a great point. And actually, another question just came in about how to deal with persons who are taking treatment for latent TB infection who may not want to take that treatment because they would rather use alcohol to excess. And I think that your point, I think, is well taken, that it should be more of a counseling approach as opposed to a lecturing approach. So I think that answers that question actually quite nicely. There was a question related to whether studies have been done related to access to TB treatment and care, in comparing foreign-born patients versus a refugee population or a newly arrived immigrant population. And if there haven't been studies done, how might a program maybe perhaps look at differences in access to treatment or how people are accessing treatment?
Yes, there is, and actually one of the task orders, and I think it may be task order 23 for the TB Epi Studies Consortium, and they were looking at the differences with foreign-born populations and trying to look at their access to care, what are the barriers to care, and what are some things that will enhance people's health-seeking behavior.
I could just join in. You're exactly right. That was task order 9. Task order 23 used a very similar questionnaire, though. So for both of those studies, there is a fair amount of attention given to how people access care and what is their help-seeking process. Because I know anecdotally we did a study in Harlem where we did qualitative interviews with people about what happened from the time they didn't feel well until they finally were diagnosed with TB. And you get stories about people going into pharmacists and pharmacists giving them NyQuil and Robitussin and things like that. And even doctors also misdiagnosing TB. So it's an interesting process. And those two studies look carefully at whether people went to a doctor or whether they went to a pharmacist or when they went to a healer in their community, someone who represents the traditions of medicine in different ethnic groups, or whether they went to a clergy person. That is something we still have to take a close look at and make those results available.
Thank you so much. Joan, a question for you regarding readability testing. You extensively talked a bit about how you looked at readability in terms of getting your messages across to the individuals in your target audience. And so let's say somebody does develop a material. How might, again, a local program who's developing a material, who's gone through some of the processes that you've talked about, go about testing the readability of a material that they're developing?
There's a couple of tools that actually are online that they could use, and you can copy and paste your text directly from a Word document into it, and it will sit there and it will do the different calculations. You specify which ones you want on some of the tools, and on others it'll just give you the whole lot that they're able to do. There's also a number of books that are out there that will provide guidance on doing things like the SMOG test and the FOG test, where you actually have worksheets and you can sit there and you could do all the calculations yourself.
On the Find TB Resources webpage, there are some materials there specifically on the page looking at adapting materials, and I think we include some of those materials. And it was a good reminder to us to make sure that we do have those things included, so we'll be looking at that as well.
Great, and I think that also hits on the point that Paul brought up quite early in his presentation as well, is that you don't have to reinvent the wheel. He actually did look at some of the previous literature that was done, and again, if you're looking to undertake a small project in your program and want to look at some of the attitudes and knowledge of persons that you're working with, you can certainly go to the literature and look at what's already been done, as well as materials, which Wanda alluded to as well. That's all the time that we have allotted today for this seminar. I'd like to thank our faculty very much for sharing their knowledge and experience with all of us, and thank all of our participants for some really good questions and input. And finally, the New Jersey Medical School Global Tuberculosis Institute provides medical consultation services to the Northeast region. You can call 1-800-4TB-DOCS with any questions regarding medical consultation, again, in our region. This concludes the conference. Thank you very much for your participation.